whilst we wait for people to continuously join, just to inform those that have joined already, so we will have a Q&A at the end of the webinar. This will be in the chat, so feel free as the presentation does progress to put any questions that you may have into the chat as we go along, and then what we will do is we will answer these at the end of the session as well. But as we're waiting, what I'll do as well is I'll give a short overview. So to be introduced to you all, my name is Simon Eves. I am working for Flen Health, who are hosting and chairing this webinar this evening. For those who don't know Flen Health, we are the creator and producer of Flaminal and Flamigel, which are distributed into the Australian and New Zealand markets, working with EBOS Group across the two markets, with EBOS Healthcare looking after our products in New Zealand, but Century Medical working with our products in the Australian market. And this evening, I'll be chairing this webinar as a support as well from Judy Harveyland. So Judy has joined, and she has over 30 years of experience in the Australian healthcare market and New Zealand as well, with a high level of emphasis on wound management and burn management as well. And then for the last 8 years, Judy has been working as an independent consultant across the healthcare sector, and we have a close working relationship between Flen Health and Judy as well. So she is able to support us locally. And then, I think let's kick things off and allow people to come in and join us as they wish. So today we have our guest speaker. So our guest speaker is Melinda Brooks. Melinda has worked in wound management for more than 25 years in a variety of different settings, from the Victorian Adult Burns Unit to community nursing, research, education and lecturing in different wound care, in different universities. So today, Melinda works in private practice as a nurse practitioner in wound management, with a high focus on aged care, community and private wound clinics, providing consultancy and education. Since 2016, Melinda and two colleagues began Wounds R Us, a collaboration which provides wound management education to clinicians around Melbourne. And today, I believe Melinda has a wealth of knowledge and expertise, which we can all learn from during this webinar, that's able to teach us about the importance of holistic wound management. So Melinda, without further ado, if you would like to kick things off, and we can allow people to join continuously.
Lovely. Thanks very much, Simon and Judy. It's a pleasure to be with you all tonight on a Monday night. So hopefully we're all fresh start of the week. I'd first of all like to acknowledge the traditional owners of the land on which I'm presenting tonight, which is the Wurundjeri people. I'd also like to pay my respects to their elders past and present, and any Aboriginal elders who might be joining this webinar. So I would like to, just say thank you to Flen Health and Judy Haviland for asking me to present tonight. There's a lot of content, and I'll certainly go through the objectives for this session, but I thought it'd be good just to give you some background as to why this webinar came about. So the Pass It On message was devised by Flen Health and is primarily intended for aged care facilities where non-healing wounds may become difficult to manage. So at times we know that wounds can get or deteriorate quite quickly. Sometimes referral to a specialist or wound consultant can be quite delayed. So we're really trying to prompt everyone to remember that a timely wound referral to a specialised consultant is really important. So we need to try and stop these wounds going on and on and on, identifying the early signs of delayed healing and trying to get on top of them a lot quicker. So the objectives is we'll discuss why wounds become non-healing. We're going to look through the continuum of wound infection. We'll also define how we can manage wound infection better. And I think a lot of that does come back to the early assessment. We'll discuss Flaminal gel when it's appropriate and what precautions should be applied. It's certainly all wound care products out there are not suitable for every kind of wound we're seeing. So we'll go through that. We'll discuss when to refer on, and then I have some case studies that I can share with you at the end of the presentation. So wound management, sometimes as a nurse practitioner out there in private practice, sometimes you feel a bit alone when you're doing the wound care, but I think it's really important to remember that, we as clinicians don't know everything. I certainly don't. And it's certainly a team approach to wound management is the best way to go. So liaising with our medical, our allied health, our nursing team is really important to seek information and find out how we can manage these wounds better. This is certainly the model that I tried to work by, holistic wound care, ensuring that incorporating all aspects of the person and the wound. So the first thing I like to ask the person who has the wound is what's concerning or bothering them most? What are their expectations? What is their quality of life like at the moment that we can try and improve for them? Referring on if I don't know. So certainly timely referral is essential. And ideally that's within the first 2 to 4 weeks of that wound developing if the wound is not showing improvement or we're not achieving the outcomes as expected. Defining the etiology, is it clear? Is it correct? Classifying the wound, whether it is healing or non-healing. Looking at the investigations that can certainly help to get the diagnosis correct, such as swabs, blood tests, venous arterial duplex ultrasounds, sometimes biopsy, whatever may be appropriate. Looking at systemic and the local factors which could be impacting on healing. And I think with, especially in our older population, there's often a lot of things going on with them that we do need to identify from a systemic point of view. Nutrition, in order for the body to heal, we know that the body needs kilojoules and protein. So if a person's oral intake and fluid intake is not adequate, that's going to be a big factor impacting on healing. Pain, sometimes I have patients who I can barely touch their wound, let alone cleanse it and remove non-viable tissue in order to optimize the wound bed for healing. So therefore, that's a real challenge. So optimizing their pain management and ensuring that it is tolerable and hopefully pain-free for them. Lower limb assessment is important as well because the limbs attached to the body. So looking at the holistic part, but also doing our lower limb vascular assessment is crucial. Education for all those involved in the care. So not just the patient, their family, the other healthcare providers, everyone that we are on the same page aiming to achieve the same goals. Local wound care is certainly important when we're aiming to heal, ensuring that moist wound healing environment. And sometimes pressure redistribution may be a factor of that. And of course, evaluating all of these assessments as we go along. So how do wounds heal normally? Well, if they did heal normally within a timely manner, I probably wouldn't be as busy as I am with work. But unfortunately, a lot of them don't progress as they should through the normal phases of wound healing. So I'll just go through that briefly. So when there's a breach in skin integrity, we may apply pressure, or the person may apply pressure, try and stop that bleeding, aiming to create hemostasis in the wound. As that settles, we see the body's immune response with inflammation around the wound that will develop and it should be present for approximately 3 days or so, with the cytokines and the macrophages and fibroblasts coming in to munch up the debris to reduce the risk of infection. If a person's on potentially steroids or anticoagulants, that can certainly have an impact on the initial hemostasis and inflammatory phase. As the inflammation settles down, we then see the body start to rebuild through the process of angiogenesis with new granulation tissue building its way up to the level of the skin. And as that's happening, the myofibroblasts are bringing the walls of the wound in as well through contraction. When you get your epithelial, where your granulation to the level of the skin, we'll get our epithelial cells. And at the end of this, we say the wound is officially healed once it's completely epithelialized. However, over the next couple of years, it does take some time for the new scar tissue and the collagen to mature and gain more tensile strength. And we know that once we have a scar, you only ever get a maximum of 80% strength in that tissue. You never gain 100% back. And certainly, again, for our older population who may have more fragile skin and other comorbidities and factors delaying the healing, it can take quite a while for that tensile strength to rebuild. So I do often recommend we keep a wound once it's healed, perhaps protective dressing for another couple of weeks or so, just while we are waiting for that tensile strength to start to develop more in that wound. So that's what should happen normally. However, it doesn't always progress like this. So certainly wounds can become non-healing due to a variety of factors. Aspects such as inadequate perfusion, if there's not enough blood flow down to the area. I'm not a vascular surgeon, so it's not something I can help with. But certainly if a vascular input is required, that would certainly be a good place to refer to. Certainly there are some medications that can help with permeability of the red blood cells through arteries that may have some atherosclerosis present. Drugs such as pentoxifylline can help with that as well. Venous insufficiency, we can sometimes manage a little bit easier in relation to edema. So looking at compression elevation at walking to try and get the calf muscle pump to return that venous flow back up to the heart. Abnormal inflammation. So again, we've got to work out what is causing the inflammation. The person may have underlying inflammatory conditions that may be predisposing that wound to abnormal inflammation. A biofilm, and I'll talk about that a little bit later when I talk about infection. If the person is immunosuppressed or compromised, they're certainly going to be at risk of infection as well. Poor nutrition, as I've just mentioned, and potentially any pressure, shear, or friction on the skin. So defining hard to heal wounds, it is a broad term that can be difficult to define, usually due to different interpretations of the term. But the key to identifying wounds that are slow to heal is early detection of the complex risk factors, and they can certainly be intrinsic and extrinsic. So this is where our holistic assessment is just so important. A lot of the research and data out there does tell us that a wound should be showing signs of progressing and reducing in size. So that would be length, width, and depth by at least 25 to 30% within the first 4 weeks. So that's something we should be looking for. Non-healing wounds can certainly present as a major social and financial burden, and certainly I see that a lot with my patients, those coming into my clinic, those in aged care, those in community where they're having to purchase their own dressings, and it can be very, very expensive for them. Also, the number of people developing non-healing wounds is certainly increasing due to changing lifestyles and the aging population that we're seeing around the world. So if we're looking at some of the factors that contribute to non-healing wounds, there's certainly patient-related factors, wound-related factors, skill and knowledge of the health professional is key, and certainly resources and treatment-related factors. So if we're looking at patient-related factors, certainly pathology. So I had a lady in my clinic today who keeps developing very small hematomas under her skin for no apparent reason. I've just gone through her medication and looking at a whole variety of things this afternoon to try and work out why is this happening. So I've actually sent her off with some full bloods and also looking at her clotting profiles and her inflammatory marks to see if there's something else going on systemically that's causing these small hematomas, because they're not related to trauma. So I feel there could be sort of a clotting aspect, and potentially referral to a hematologist would assist with that. Medical conditions, and a lot of people do talk about diabetes being one of the main ones that will impact on healing. And we do know uncontrolled diabetes and elevated blood sugars will have a big impact, along with other conditions such as anemias, autoimmune conditions, inflammatory conditions. Medications, I've just mentioned the steroids and the antiplatelets, anticoagulant drugs are the main ones, probably along with cytotoxic medication. If the person has any specific allergies or sensitivities, psychosocial. So we know there's more and more evidence coming out linking depression and anxiety relating to pain and wound-related pain to delayed wound healing also. Certainly concordance, and I don't like to use the word compliance, but certainly the patient owns the wound. So it's certainly up to them whether they choose to take on board recommendations or whether they don't. And I think if they don't, just being mindful that healing may not progress and it may become non-healing as a result of that choice. So wound-related factors, we're looking at duration and senescence. The size, so like I say, it's not just sort of length by width that I look for when I'm looking for signs of improvement in a wound. I'm looking at the wound bed tissue. If it was fluffy and we're seeing more granulation, that's certainly going to be a positive sign. If there's signs of inflammation, infection, if the anatomical site's an area due to contamination, like the sacrum perineum, the response to treatment that's been put in place. So really assessment and evaluation should be at every dressing change. And also ischemia there, again, coming back to oxygenation and perfusion. So the skill and knowledge of the health professional is so important. The attitude of the clinician, I'll often do teaching, and sometimes there'll be nurses sitting there in the room on their iPad doing their notes from the morning, really not even listening to me. And I feel like saying, if you haven't got time to listen to education, you probably shouldn't be in the room, get a little bit old and grumpy. But there's got to be interest. There's got to be interest shown for the person with the wound, as well as, the task that they're doing. Perceived professional failure. And look, sometimes we try things and things go backwards, but that's okay, as long as we're using best practice evidence behind us when we're making that clinical decision. Aiming to identify the patient's concerns because they're the ones suffering with the wound. Identifying, discussing any potential barriers. Providing support, liaising with other healthcare professionals, and I certainly often do. And remember, care is for the whole patient. It's not just for the wound. So looking at resources and treatment-related factors, certainly early intervention based on the evidence we have available. Looking for that reduction in wound size of 25 to 30% within the first 4 weeks. Staff education, I would add to that family education when we're dealing with patients, particularly in an aged care setting. Involving the family often really does help in getting the message across, also for the person who may not be able to comprehend that. And, unfortunately, cost and availability is a factor we need to address. Okay, so that's looking at the patient and other related factors in relation to non-healing. I just wanted to go through in a little bit more detail about wound infection itself. So this document was released in March 2022, which was the 3rd edition of the wound infection document in clinical practice. And this is really our Bible that guides our clinical practice in assessment, management, and prevention of wound infection. So a lot of nurses, carers, staff say to me, "Yep, the wound's infected." And I go, "Great. What level of infection? Where is that infection on the spectrum?" And that's just like me saying to you, "I've got, a car." That could be a 30-year-old bum, or it could be, a brand new car. So what we need to bear in mind is the level of infection, because if we can assess and define that accurately, and this is purely based on our clinical assessment, then our management plan is going to be correct. So I'll just run you through what we talk about in the continuum. So we know that our wounds and our skin, we're colonized, we live with bacteria, fungi, spores, and viruses on our skin all the time. But most of the time, they're in low enough levels, they're not causing a response in us, the host. However, when those usually bacteria, start to multiply, we might see some signs of local infection. They could be covert or very subtle signs, or they could be quite overt signs. So that's things like hypergranulation, bleeding, friable tissue. With your covert signs, maybe some epithelial bridging that develops and then breaks down, and the wound's just not improving as you would expect. Your more overt signs are things like erythema, and that's maybe a small amount of erythema, a centimetre or 2 beyond the wound margin. Some local warmth on the skin, some swelling, potentially purulent discharge, wound getting larger, and potentially malodor. Spreading infection. So with our local infection, the bacteria are really sitting more or less around the surface of the wound. They haven't infiltrated yet deeper into the tissues. But with spreading infection, they've gone through the little capillaries, started to spread under the skin, and we are seeing more spreading signs of infection here. So certainly redness or erythema extending more than 4 centimetres beyond the wound margin. You may see some lymphangitis, some crepitus if you're palpating the skin around the wound as well. And the person certainly will likely complain of more pain if they've got sensation. At the point of systemic infection, it's certainly travelled through the body, and we need a more systemic approach to wound care. So as I said, this assessment of infection is based on your clinical judgment. We don't need a wound swab result to tell us the wound has signs of local spreading or systemic infection. We only swab the wound to identify the microorganisms. So be alert for clinical indicators of biofilm, such as the wound failing to respond to appropriate antibiotic treatment, the wound's just not progressing, poor granulation that's friable, perhaps low-level erythema, and chronic inflammation. So when we're talking about management of the various levels of infection on the continuum, contaminated colonized wounds, we don't normally need to debride aggressively as with sharp instruments. Normally an inert product such as cleansing solution such as saline and a simple dressing is enough to ensure we're promoting the moist wound management principles. When we talk about local infection with signs of either classic or subtle signs, debridement and post-debridement care is required, and that doesn't have to mean conservative sharp wound debridement. Debridement or wound bed cleansing can be done with your plastic forceps, your gauze swabs, not cotton balls, and a probably better solution than saline. So at this point is where we introduce our topical antiseptic cleanser or a surfactant soak, and we would also go to a dressing that's antimicrobial to reduce the bacterial load. When we're talking about spreading infection, we'll be doing the same thing, but at the point of spreading infection, that's when we need to then take a wound swab and identify the organisms because we need to treat it with oral antibiotics. So local infection is often the point where I find a lot of clinicians are requesting to take a wound swab. It's not needed at this point unless it's not showing signs of improvement. So it's really at the point of spreading infection where we would be taking that wound swab. So when we're talking about the biofilm-based wound care approach, there's the document talks about a step up and a step down approach. So certainly the first few days would be quite aggressive debridement with whatever method is appropriate within your scope. Empirical topical antiseptics and potentially systemic antibiotics, depending on what level of infection you've defined. Managing the host factors. So this comes back to our holistic assessment. So offloading, compression, potential diabetes management, nutrition, pain, etc. So when we talk about swabbing, the Levine method of swabbing is the most accepted worldwide. And that involves making sure we do cleanse our wound with saline and not an antiseptic before the swab is taken. The rationale for that is that we need to remove any non-viable tissue or debris off the wound base. We don't want to be swabbing the top of the wound, the surface we're seeing. That's where our colonized and contaminated flora sit. Where I gave the definition of spreading infection, bacteria have gone deeper through the capillaries. So cleanse the wound with saline, not an antiseptic, remove non-viable tissue. You need to tell the person it could be a bit uncomfortable and hurt. So to suppress the swab into the red granulation tissue, that's the fluid we're trying to get out of the cells to send off to the lab. Ensure it's always in a moist medium and doesn't need to be refrigerated. So that is the Levine method, and that is based on best practice. So the step up, step down approach, as the wound's progressing, and again, you need to evaluate at every dressing change. You're hoping to, hopefully a short course, a 5-day course of antibiotics will be enough. And then as the wound is showing signs of improvement, you may wean away from your antiseptic and antimicrobial dressing back to saline and an inert dressing, just depending on how it goes. You may also need to consider more advanced therapies if the wound's not improving. So certainly management, the topical antibiotics, always refer to therapeutic guidelines as a guide. If a topical antibiotics, things such as mupirocin and other ointments, they should only be very short use, short-term use, so 7 days or so. They shouldn't be used ongoing. Did see a patient regularly who was having, I think it was some flamazine, and had been used for 6 months on a wound, which is just far, far too long. So we do have to be very mindful about antibiotic and antimicrobial stewardship. So just a little bit more in relation to biofilms and delayed wound healing. So the biofilms, even the scientists are very confused around what actually creates a biofilm. We know that they're there, they're not visible to the naked eye. When we're seeing signs of healing, biofilms are likely present in around 80 to 90% of chronic or non-healing wounds. So that's why we do change from a inert, simple saline type cleanser to an an antiseptic, and also from a simple dressing to an antimicrobial dressing to try and penetrate through that biofilm, because saline and inert dressings won't do that. So the biofilm matrix actually forms a physical barrier on the wound. So basically, if you try and clean it using saline or your forceps, it won't get through that physical barrier. It's only antiseptics and antimicrobial products that actually will. So with excessive wound exudate on the wound bed, this will certainly maybe linked to biofilm development and infection. So if a wound is hard to heal and not responding to the appropriate treatment, we should certainly suspect the biofilm's there. So the criteria of potential biofilm in a wound, and this is similar to what was in that first table I showed you. So if the wound's failing to respond with antibiotic treatment, if it's recalcitrant to antimicrobial treatment, and certainly we don't often use the same dressing for beginning to end of wound healing. As the wound bed environment changes, often we'll need to change our dressing regime as well. And if you've got those other signs like low level inflammation, erythema, potentially some hypergranulation as well. So really with our biofilms, when we're suspecting a biofilm on the wound bed, we really do need to cleanse wounds well or debride. And like I said, it doesn't have to be with a sharp tool. It may be with your gauze, your forceps, potentially a curette. So this brings us to Pass It On, the lovely document that's been developed by Flen. So it's a 2-page back to front document, and I'm going to just break it down and run you through it a little bit more. It really is, I feel, quite an easy, simple guide that you can use to help assess and manage these wounds to try and prevent them from becoming non-healing, and also trying to alert when you should be referring on. So we have the PASS, then it on. So P for presentation, patient presents with a newly developed wound or deteriorating wound, and there's some key indicators there that may show the sign the wound is deteriorating. The assessment, certainly consider potential underlying causes of the wound. Assess and document the location. Please use anatomical terms. I'm getting old and grumpy, and I sometimes go and see a patient who may have 4 wounds on the foot, and it just says left foot, left foot, left foot, left foot. If we use anatomical terms such as malleolus, medial, lateral, anterior, posterior, it's a lot clearer. Now I've lost my point. There we go. Duration, size, and tissue type. Use Flaminal as a first-line treatment for 2 to 4 weeks. So again, we're not saying to use it forever, but we should be seeing a response in that time frame. And if it responds, certainly you could continue to use it. Use caution for wounds below the ankle. Refer for assessment, and I'll talk about that a little bit more in a moment. So with specialist, if a person has a limb threatening or life-threatening wound, if you refer immediately to acute services, potentially high-risk foot clinic, emergency, and inform the wound specialist according to your local protocols and pathways. If there's no signs of improvement in that 2 to 4 weeks, then refer a patient to a wound specialist. Follow up on referral after the number of days that is stated in your local guidelines and policies if the person has not been seen by a specialist clinician. So really important, we don't let it go on and on. So try and solve. So complete the holistic wound assessment and address any obvious cause in relation to potentially pressure injuries, nutrition, comorbidities, etc. So check if there's signs of local or spreading infection. If yes, again, refer to wound specialist for review. And if needed, prescribe oral antibiotics as per therapeutic guidelines. Again, you've got some little key indicators there that will show us signs of the wound improving. So dress the wound as per guidance below. It's a simple pathway that clinicians can use. So we'll go to that now. So the patient presents with the wound, assess the type of tissue. So if it's black and necrotic, the recommendation is certainly to keep it dry until the wound and the holistic assessment has been done. In the interim, you could apply a low adherent dressing and refer on to a specialist. The reason being, any wounds below the ankle, we've really got to be mindful. The person doesn't have to be a diabetic, but if they have peripheral arterial disease, any form of ischemia, any other potential underlying condition, sensory neuropathy, we need to be very mindful of hydrating that necrotic tissue. If the wound is yellow and sloughy, if it's slight to moderately exuding, we could apply Flaminal Hydro in a 5 mm thick layer and cover with an appropriate secondary dressing. If it's moderate to heavily exuding, then the Flaminal Fort would be much more appropriate there with a more absorbent secondary dressing, like a super absorber, for example. So Flaminol can be left in the wound for up to 4 days, depending on the level of exudate, ensuring that the gel structure remains intact, that it's not weeping. So if you've got very heavy, wet, leaky venous ulcer on a lower limb and the Flaminol's running off, then it's probably not going to be appropriate at that time. Certainly, caution is needed for potential sinus tracts or any undermine areas where we don't know where that wound is tracking to, where the depth is unknown. And again, you should be referring on to a specialist. So just in relation to how Flaminol is a little bit different, I think I've been using Flaminol since day one when it came out, and it certainly is a favourite of mine. The reason being it's so easy to use. So Flaminol is different to your other traditional hydrogels for the fact it has water, calcium alginate in it, which is what allows a Flaminol to absorb exudate into the gel and hold it. It does aid in autolytic debridement, and it's got 2 antibacterial enzymes that are actually found in our spit, and that's lactoperioxidase and glucose oxidase. So they're the enzymes that actually reduce the bacterial load in the skin. So it does come in a variety of sizes. The little 10 grams can be started with, or the 50 grams for longer lasting. Certainly application, I always put it on my dressing pack and then use my faucet so I can use it at various times. It can certainly be applied with a nozzle or spatula, however it's going to be sort of appropriate for the person. And it certainly is multi-use. It's not a single-use gel, which is great. Secondary dressing is always going to be required. So caution when we shouldn't use it. So as I mentioned before, certainly where the wound below the ankle, where we're not sure about arterial status or other factors that may delay the healing. If there's dry adherent eschar, again, that's more precaution below the ankle or below the knee. I've certainly had areas on other parts of the body where the eschar started to soften, and I've used Flaminol to hydrate and moisten it to lift it, but that's more been on the upper body. Or where there's signs of spreading infection and potentially it's not responding to the Flaminol in reducing the bacterial load, and where systemic antibiotics haven't been effective either. You just need to work out what else is going on there. So when to actually refer on? So I've just highlighted the points in the first part of the flyer, which I think is really useful. So if no signs of improvement in the wound within the first 2 to 4 weeks, refer to a wound specialist. Certainly follow up on referral after a number of days once you've started the local guidelines and if you feel it's not improving again. So certainly check in relation to the solvent part, check if there are signs of local or spreading infection. Again, are we treating it correctly topically and systemically? Okay, so I'm just going to go on to a couple of case studies of some patients that I've used Flaminol on in my experience. So this is a lady, she's in her 90s, bedbound, full care, who has had a stage 4 pressure injury on her sacrum. I've just found it's become quite fluffy of recent times. We are getting healing despite it being stage 4, even though realistically we thought it would be a non-healing wound. And what I've found is that tenacious fluff, when I've swapped to Flaminol Hydro, really has started to break it down quite nicely, so that with the curette, I've found I'm able to remove the fluff quite easily with an appropriate secondary dressing on top. This is the lady with the burn. Unfortunately, I didn't get the follow-up image when it had healed, but certainly any superficial partial thickness burns, I find Flaminol amazing in reducing pain. It's creating an promoting autolytic debridement, nice moist wound environment. So certainly the Flaminol Hydro at this point with the low adherent dressing is perfect. It can be a daily, second daily, third daily change, depending on where it is, until that eschar there is ready for debridement. So this was on a thigh from hot water. And I think it only took about 3 weeks, 4 weeks or so for that to actually heal really nicely. It's a gent of mine who had a terrible, unstageable pressure injury on his buttock. And again, he was quite advanced stage, lots of comorbidities, immobile. I didn't use Flaminol initially on this. I used a povidone iodine soak until the body broke down that necrotic tissue. And then once I was able to, once the wound reduced in size a little bit, I did swap over to some Flaminal to aid in the autolytic debridement. He healed amazingly. I can't believe how fast he healed. We certainly optimized his nutrition, his offloading, all the other factors as well. But I just found it worked quite well for him. It's another lady of mine who was in my clinic who actually saw today. She's brought her mother-in-law in to see me, who had this tiny little wound on her foot in January. It had been there since about the December. I tried various primary dressings on this wound. She ended up getting a couple more. I did swabs, I did blood tests, I did everything to try and get a diagnosis, because initially she told me that it originated from footwear. So by about the April, she was telling me one day about she goes and sees her mum every week, and her mum lived out of Melbourne. And then I said to her, we were talking, having a chat. I said, tell me, where does your mum live? And she goes, oh, down on the Mornington Peninsula. And I went, penny had dropped. So I did a PCR swab for Mycobacterium ulcerin, came back positive. So I sent her straight off to infectious diseases. And I think we used Flaminal then until healing. The dressings were not the main issue here. It was treating the underlying mycobacterium systemically. And that's why we had seen such varied results. So she healed beautifully then. And I just put this one in because I do see a lot of tendon exposure on calves and Achilles tendons, and a lot of, clinicians often mortified, how can we ever heal this? This is where you really need to know your underlying anatomy and physiology. Knowing that tendon is under the subcutaneous layer, it's in quite a wet environment. We tend to go more on the wetter side of wound healing here rather than just moist. So I've used Flaminal, I don't know how many times over the years, on exposed tendon and had great healing results. The body will never rebuild that fatty layer that's been lost to rebuild the tendon. Granulation tissue will grow over tendon in a nice moist environment. And the beauty of the Flaminal is we've got our antimicrobial aspects, which you don't get in a normal hydrogel. And this is just another young gent that I saw at one point who had this ulcer. Again, I tried various things, got a little bit of improvement, went backwards, did try Flaminal for a while, and then it just seemed to stagnate. I ended up sending him off to dermatology because I wanted to biopsy and he didn't want me to. He was a bit afraid of needles. So I went up to dermatology. They biopsied, did further investigations, couldn't find an etiology, and actually defined this as a pyoderma gangrenosum wound. So really it's a diagnosis excluding everything else. There's no test to define it. I lost touch with this gent. He sort of went off and did his own thing. I'm not sure if he went back home, but so I'm not sure what the outcome was. But again, I think it just demonstrates that we need to know what else is going on inside the body to get diagnosis right. So that's it from me. I hope you enjoyed the presentation. I do have a list of references there as well, and certainly happy to answer any questions.
Thank you, Melinda. Thank you. Very, very insightful. So guys, for the audience, if you do have any questions, we will open up the Q&A. So feel free to put any questions that you may have from Melinda's presentation, put it into the chat, and we can put them to Melinda to see how she would best deal with your queries.
Don't be shy.
How about I started off with one question about painful wounds, Melinda,
Yeah.
and thank you so much. That was brilliant presentation, really holistic view of all the factors to consider in managing really quite complex wounds. But yes, painful wounds. I mean, I hear different things, but how do you think of Flaminal when you have a particularly sensitive patient who has a painful wound? Do you still use Flaminal? Is it a positive?
I do.
You think of it positively. So let us know.
I do,
your
especially
perspective.
Yeah, especially in a superficial or partial thickness burn, where it is so painful because the nerve endings are still intact. It's very heightened sensation. I find that patients tell me it's quite soothing, which is good. And I think being that thick gel, and it does need to be applied that 5 ml thick, they do tend to find it quite soothing, is what they say to me, and that the pain is reduced. I have a lady in my clinic at the moment who very, very sensitive, very painful. She's the lady coming up in the little hematomas. So I started last week. We're using Flaminal on her wounds, which is great. But even that with a simple non-adherent dressing on top, there was still some sticking on the peri wound. So what I'm doing now is putting the Flaminal silicone contact layer over the Flaminal and then a non-adherent pad on top. And there's no sticking happening now at all to the peri wound. So that has worked well.
Excellent.
Yeah,
Great.
and then a couple of
Thank
a couple of questions. So a long-term ulcer like a wound, macerated edges, using Flaminol, but I'm wondering how it would protect the edges. It's a white in color. Is there a best practice that you would have for protecting the wound edges? So yeah, if you would like to answer this, and then maybe I can answer the question around the white color with the Flaminol.
Yes.
Yeah.
So definitely if I'm using Flaminal, I would 99% of the time have a barrier cream, barrier wipe around the peri wound skin just to protect any maceration, although I really don't find it tends to spread and cause many issues in relation to maceration. So definitely a good barrier is important, and I'll let you answer the white.
Yeah,
sheet.
so when it comes to the white aspect of Flaminol on the edges of the wound, this is the alginate that is in the Flaminol. So this creates a crust, shall we say, around the edges of the wound. So if you were to apply Flaminol Hydro or Flaminol Forte onto, shall we say, safe or kind of intact skin, shall we say, not a wound and not a skin breakdown, then what you will find is the alginate flakes will become very white and crystallized. So as this disperses from outside of the wound on kind of an inside out action, then it will go on the edges of the wound and it will become white and flaky. And this is just alginate. So this is not an issue. All that will happen is next time that you come to do normal wound cleansing, these white flakes will just naturally wash away. So there's no issue as such. And if we follow that TIME acronym of tissue, infection, moisture, edges, and surrounding skin, we utilize Flaminol in that for the edges and the surrounding skin to protect that area. And as Melinda said, with maceration, we shouldn't have any maceration there. And then another question was around, can we use Flaminol or have you used Flaminol on skin tears?
Definitely. So my general principles again around best practice on skin tears is silicone-based foams work really well. If after say 2 weeks, and that's often 2 to 3, 4 weeks when I get the call to come in because it's not improving, they say it's infected. I go, great, but what level of infection are we talking about? Usually local, which is good. So that's when we go from our saline, our silicone foam, and we go to an antiseptic with an antimicrobial. So I say, that's fine. Continue with your silicone foam, but let's put the Flaminol underneath. And that's all you need. It's reducing the bacterial load.
Yeah, I completely agree.
So what
So
about
using
Oh, sorry, go on. Go on. You go
Just
on.
the second question from Grace, using Flaminol and wrung out normal saline gauze. So Grace, either it's me or Jen or Kate, because that's a practice we do. That saline soak gauze. I don't always. It depends on the wound and how wet it is. If it's already a fairly wet wound and I'm putting Flaminol Fort on, I don't moisten my gauze. I would just put it on the gauze to keep it in the wound, because I worry if I just put the super absorber pad on top, it'll potentially suck the Flaminol in. So sometimes I might, just to keep it, especially if it's a little bit of depth, half a centimetre, I might put it on the gauze just to physically keep it in on the wound bed. But you can. I don't think there's any issue with that. Simon, do you have any comments, or Judy?
No, there's no issue. As yeah, it's whatever works best for you in your clinical practice. We would never as a company say you need to use X secondary dressing. Flend Health, we are very much focused on primary dressings and solutions. So we say any secondary dressing that is up to your clinical judgment, the only guidance that we give is it shouldn't be an active secondary dressing, i.e., say an Aquacel. You could use an Aquacel foam or a Mepilex foam, etc., but you just can't use an Aquacel AG or a Mepilex AG. That's our kind of recommendation, because we don't know how our enzymes will interact with the AG, and we don't know how the AG will interact with the enzymes. Whereas, yeah, you can use any non-branded or any branded normal foam, film, absorbency dressing, super absorbency dressing.
Probably just one contraindication there, I'd say, in relation to secondaries, not to use something occlusive like a film or hydrocolloid, as we don't use, when there's signs of infection anyway, we don't use occlusive dressings. I always love this question.
Yeah. What is the difference between the Flaminal Hydro and the Flaminal Forte?
Flaminal Forte. Did you want to answer, Simon, or
yeah. So literally, the only difference between the two is the alginate level. So it really just depends on moisture. So I know you say Forte in Australia. In Europe, we say Forte. I don't know why. Maybe it's because we're a Belgian-owned company, and it was Forte that was introduced to us. But the blue one, the Flaminal Hydro, its alginate content is 3.5%. What this actually means in practice is it absorbs around 16 times its own body weight in fluid, whereas the Forte is an alginate level of 5.5%. So this means that it will absorb around 33% times its own body fluid. So you've got double the amount of absorption with the Forte than the Hydro. So it just means that the Hydro is indicated for a low to moderately exuding wound, and the Forte is indicated for that moderate to highly exuding wound. And that is the only difference between the two, because a lot of people think one is for infection and one is not for infection, but that is not the case. They both have exactly the same antimicrobial efficacy. It only comes down to absorption, and that's why we want optimal moisture. So if we've got a high level, we'll step up to the Flaminal Forte, and if we've got a low level of moisture, we'll step down to the Flaminal Hydro. So we have that kind of step up, step down methodology. Any other questions at all? See that Heidi is typing, so see.
Good.
So what about a dry wound, Melinda? So if you had an ischemic ulcer that's quite dry, how would you manage that? How often would you change it? What would you use in that situation to really maximize the moisture in that wound?
If it's ischemic, I probably wouldn't use the Flaminal, because if there's not enough blood flow, if you put a gel, any kind of gel on an ischemic wound, and they've got peripheral arterial disease and other complications, then you're going to potentially create an environment for wet gangrene that can lead to amputation. So I would keep it dry. Simple povidone iodine paint, get vascular review, be cautious. And then perhaps down the track, they might have done an arterial duplex and other investigations to say, there is enough blood flow. Yeah, we can heal this. And so as the body will break down that necrotic tissue and eschar itself through the process of autolysis, once it does become wet and you can take it away and you've got some moisture underneath, then we could potentially look at it. But just be cautious in the interim until we know what we're dealing with systemically.
Right.
If you use a lot of Flaminal on diabetes-related foot ulcers, not really. Not really, because again, there's usually peripheral arterial disease, sensory impairment, whole lot of other risk factors. So I'm very mindful, unless I know what their arterial duplex is telling me, all of those other factors. I think I got Grace's questions. I don't know why. I didn't see the other ones. They just popped up.
No, so yeah, Grace has just said thank you. for
Thank
the
you.
answers. Amazing webinar, Melinda. And then we have, I was typing at the moment in the chat. We have two going on. We have one in the chat,
Good.
one in the, yeah. Is Flaminol good
Ah.
for skin lesions, I would assume?
Good question, depending what kind of lesion you're talking about. But you know where I find it works beautifully? Shingles lesions. Really painful, crusty, they start to erupt. We're treating them systemically with the antivirals, but from a topical perspective, I find it works really well to use a Flaminol. And sometimes, depending on how big the area is, I might put a non-adherent dressing on top, or we might just put the gel on 2-3 times a day, the Flaminol Fort, and it will just reduce bacterial load, the crusts come off, and it heals beautifully underneath, and fantastic, really good for pain, for shingles. Probably another answer to that is BCC squamous cells as well. Yes.
Yeah.
I do.
Great minds
I
think
do.
alike.
Yeah. Especially in aged care where they're not for removal. Hopefully they are for an SCC because it metastasizes, but BCCs a lot of my older people live with. I say if it's not sluffy, if it's clean, it's not an issue. Put a simple foam dressing on, leave it for a week. If it becomes sluffy due to bacterial load, again, local infection, introduce your antiseptic and introduce your Flaminol with a usually silicone foam dressing twice a week. Done.
Do you treat wounds any differently if they've been through radiation following a BCC or SCC?
No, because I mean, that's happened, then we're sort of back to just providing the cancer cells are gone, we're back to that normal wound healing environment. Yeah. And I like the fact that, with Flaminol, even if it's no signs of local infection, sometimes I'll still use it just to prevent it from happening.
Absolutely.
Yeah, it's something that we promote at times, is using Flaminol prophylactically. Because
I do.
Yeah, I know we follow the antimicrobial stewardship and etc., but because Flaminol is, as you mentioned earlier on, with the glucose oxidase and the lactoperoxidase, the naturally occurring enzymes that are found in our bodies, with this, it's very, very unlikely that we can build a bacteria up to this, because we build a resistance up to this, sorry, because of these free oxygen radicals that are created from the enzymes. They're all slightly different, and someone described it to me the other day as they're all like humans. Shall we give an example? We're all on here today. We're all different humans, but we all have different hair, different eye colors, different skin colors. We're all slightly different, and it's like this with the radicals that are created in Flaminol. So the bacteria isn't clever enough to make the build a resistance up to this type of oxygen radical, because once it builds a resistance up to, say, a hand, then the next one that will come out will only have 4 fingers, and the next one will only have 3 fingers, and then they're all slightly different, so the bacteria can't build a resistance up. So with this, using something like Flaminol prophylactically is somewhat quote unquote safe, because we can use it to prevent from progressing, shall we say. What about chronic non-healing pine nodal sinuses, or non-healing after surgical debridement?
If we're talking specifically for pilonidal sinuses, I'd say you just need to be careful depending on the depth and if there's undermining or tracking, because if you can't palpate the end of that wound, I would certainly not put a gel or a powder or anything in that I can't physically pull out. I would normally go for a material, such as a gelling fiber or something that I can physically put in and pull out. You've got to be careful with pilonidal sinuses unless it's shallow. Yeah.
And then the second was about chronic non-healing wounds after surgical debridement.
Oh, definitely.
Yeah.
Good choice. Yeah.
Yeah. And then in pine nodal sinuses, I believe that they've just responded again saying shallow wounds. So my assumption would be a shallow pine nodal sinus.
It would be okay. I guess you just got to be mindful with pilonidal sinuses, because of their location, it can be an often very moist, sweaty area. So you don't want there to be the gel coming out of the wound or not contained in the dressing where you're having extra moisture in that area. That will lead to an increase in bacterial fungal load. I usually
It
for pilonidal sinuses will put something in, pull it out.
yeah. It depends on, I suppose it depends on climate as well, because
Yes, yes.
with Australia, you have such a higher, more humidity, more sweaty, shall we say, for these patients, shall we, that we have. Whereas just a little bit of experience that we had during the COVID pandemic in the UK. What our UK team did is they worked very closely with our community nurses, because a lot of our community nurses deal with pilonidal sinuses as a wound. But a lot of these patients are mobile, so it isn't that the community nurses have to go and see them. The patients are just a part of their round, shall we say. So what they did is they used Flaminal Hydro into their pilonidal sinuses, but then they used a gauze as kind of a wick to
Yeah, yeah.
basically put the Flaminal into the pilonidal sinus and then plug the entrance of the pilonidal sinus with the gauze to avoid what you've just said, Melinda, avoid it coming
Yeah.
out. But with this, it really led to a shared care. It led to patients' self-application with these pilonidal sinuses and then being seen every 2 weeks by the community nurses rather than being seen every 2 to 3 days, which staff pressures and things like this, especially during the COVID pandemic, was really good because we were able to take a lot of those patients off the caseload of the working with that community team. And then they've said, we have a young boy with pilonidal sinus wound, hasn't closed for about 2 years after surgery. Not sure why. We've just sent him to a plastic surgeon for their opinion.
I'll be investigating more.
Yeah. Yeah, going back to what you said earlier, Melinda, it's the whole of the patient. It's not the whole of the patient. There's obviously an underlying factor as to what's going on there. Have you ever used Flaminal in a large wound with a vac dressing?
No. No.
It is something that does happen with
Yep.
our experience and our affiliates. So we have 7 affiliates across Europe. So the UK, Germany, the Netherlands, Luxembourg, Belgium, Italy, and Czechoslovakia. So it is something that we do have. I have your email address. So if you're happy to, I would be more than happy to send you over a couple of case studies directly that reference using Flaminal with vac therapy. It has been done, it is done, but maybe just not something that you've looked into at the moment. And then that is it, and we're coming to the end now. So thank you everyone for joining, but mostly thank you, Melinda. Thank you for a very kind of interesting, informative webinar. I think it was, very, very, very good, and I definitely took a lot from it, and I'm sure a lot of the audience did as well. Thank you everyone for joining as well on a Monday evening. I can appreciate that. Monday evening coming on 7 till 8, it's not ideal, but so thank you for giving up your time. And if there's any queries or any questions, please feel free to reach out to Melinda, but also Judy as well. And I will send everyone a follow-up email after this from our Phlegm Health. So thank you all. Wish you all a good rest of your evening and a good week ahead.